My name is Lynsey Brandt. Can those of you over there hear me? Got a big mouth. Okay, wave if you can't. Thank you again for coming out to hear about this important topic about medication use in older adults. I thought I would start by telling you just a bit about myself. I am originally from Pittsburgh, Pennsylvania. Did my college there, which was pharmacy school at Duquesne University. I have worked in hospital pharmacy and community pharmacy as a pharmacist at Eckerd, which is now Rite Aid. Yep. And then decided to go to medical school kind of right at the end of my pharmacy training. Did my med school at Pitt. Then ventured out here to Philly, did my residency at University of Penn in internal medicine. Went down to Hopkins for a couple years for the geriatrics fellowship, but missed Philly too much. And so now I'm back here on faculty at Penn going into my second year. But what I have planned to talk about for this evening is just starting with an overview of kind of the problem of medication use in the elderly. Then I thought I would focus the talk by talking about 5 common problems that we see in the practice of medicine and geriatrics, and giving you some tips for how to avoid these problems. And then I wanted to leave a lot of time at the end for discussion, because I'm sure you guys came here perhaps with some questions in mind. So a gerontologist usually is a more general term that refers to anyone who studies aging and or older adults. So a lot of times these could be people with PhDs in psychology, sociology, many varied backgrounds. And a geriatrician is specifically a physician who takes care of older adults. But if somebody calls me a gerontologist, I'll go with it. I study older adults too. So this is my disclaimer. I want to make it clear that I'm going to review some general principles of things. And if I say something about a medication, if I say something negative about a medication that you or one of your relatives is on, do not be alarmed, because any medicine in any given patient could be the right choice of therapy. I'm just going to be speaking again in general terms. And like I said, you have to individualize the therapy. Okay? All right, good. So, all right, just some background. So, folks over 65 make up 12 to 13% of the U.S. population, but consume roughly 35 to 40% of prescription drugs. And I would venture it might even be higher than this at this point. And older adults, looking at these numbers, so 90% take more than one medication, 40% are taking more than 5 medications, and 12% are taking more than 10 medications a day. I know that whenever I have a cold or something, or need antibiotics, it's hard for me to remember to take one medicine like 3 times a day. So I can't even imagine taking 10 medicines a day. As it says here, 10 to 30% of elderly hospital admissions are drug related. So again, hoping today to give you some pointers to avoid those sort of problems. Medications and how our bodies change as we age. So there are changes in our whole physiologic system, things like changes in the kidneys and the liver and the amount of body fat versus the amount of body water. And I won't go into too much detail, but suffice it to say, the body processes medications differently as we age. So, for example, there's something called the blood-brain barrier that's supposed to keep things from getting into the brain. Well, it's more permeable. It's a little easier for stuff to get across it as we age. We're more sensitive to a lot of the drugs that get into the brain and can make you sleepy, those sort of effects. Also, the process of removing drugs from the body is overall less efficient as we age. So drugs hang around longer. Specifically, kidney function naturally declines as we age. Liver function, not as much of a problem, but in certain disease states, the liver can also be affected. Okay. Good. Thank you. So I thought I'm going to teach you guys kind of like I teach my medical students and my residents. We're going to have a case. And you guys are going to hopefully help me kind of diagnose some of Ida's problems. So Ida is not a real person. She's an amalgam of many patients I've seen through the years. So consider her 85-year-old woman. She's got some high blood pressure and some arthritis. She was hospitalized for congestive heart failure, which is a condition when the body builds up too much fluid. It can be hard to breathe and hard to function. After the hospitalization, she wasn't quite strong enough to go home, so she went to a skilled nursing facility for some rehab or some therapy before she went home. And she's got a doctor at Penn Radnor, she's got a heart doctor over at Lankenau, and oh, her orthopedic surgeon is over at Bryn Mawr. And as you might imagine, she had several changes in her medications after her hospital stay. So, all right, continuing with Ida. So Ida, she is on a water pill, but she doesn't take it at least 3 times a week because, it makes her have to run to the bathroom. So when she wants to go to her bingo or when she wants to go play cards, she skips it. and which can probably be bad for her. Then her knees were hurting, so she thought she would start on some ibuprofen that she got at the drugstore, and just started it on her own. Then she noticed a little later her legs were swelling more. And then finally, Miss Ida was having a hard time sleeping, and so she took one of her husband's nerve pills last night to sleep. So without belaboring the point of Ida, you can see this just sets the stage for what happens every day in my practice. So here are the 5 common problems I'm going to touch on, and maybe some of you read ahead and already saw. So the first one, like we started to talk about, lack of a complete medication list. It's really a danger. Adverse drug reactions, the problem of non-adherence, and I'll define some of these terms later. I'm going to talk about some specific drug categories that are of particular risk in older adults. And again, something called polypharmacy, which is something we geriatricians specialize in. Okay, so problem number 1, the lack of a complete medication list. So like we said, medications get changed when people go in the hospital. So some medications get stopped. Maybe things like if somebody's taking Fosamax for their bone density. That's just not something that is necessary to be taking while they're in the hospital. They've got other problems, their pneumonia or whatever important thing has flared up. So then when they come home, maybe it's not on their list anymore and they don't think they're supposed to take it anymore. You can see how things get dropped off of the list very easily. Also, I want to point out there's something that takes place called medication substitutions based on something called the formulary. So anybody know what a formulary is? Yes?
The list of the medications that the facility ordinarily stores.
Exactly. And when you think about it, it kind of makes sense. I mean, cholesterol, there are, 8 or 10 different cholesterol medicines called statins. They can't keep all of those in inventory. I think the expense and just the logistics of that so would be prohibitive. So maybe they keep, Lipitor and Zocor. But if you take Crestor, when you go in the hospital, you get put on a substitute. Then you come home, and again, the doctor may not know you took Crestor at home, and now they give you a prescription for Zocor. You could very easily accidentally fill that and be taking 2 drugs in the same category. So it's very dangerous. So just beware around the time of the hospitalization. So the other problem, so multiple prescribers, like we were talking about, doctors in different systems, lots of cooks in the kitchen can be very dangerous. Lack of just complete records, again, like I said, the patient was in the hospital, they come to their doctor, we don't know what happened in the hospital. Maybe 50% of the time we find out for sure. And then the whole issue of self-medication or over-the-counter medication use. Don't get me wrong, it's great that there are medications that people can get and treat themselves with, but sometimes it can be dangerous. Sometimes they can go against your medical conditions. All right, so I've made my slides of the problems and then the theoretical solutions here. So one thing that I love is people who bring their medication bottles to the doctor visit. Just stick them in a bag, bring them in. I tell people this is like Christmas. I love it. It's like opening presents. I go through and I see just what's in those bottles. I can tell when's the last time they refilled it and how often they've been taking it and really get a sense of what's going on in their world. At least definitely do this on an initial visit with a new doctor if you can. And especially after any, I use the word transition of care. That's the word we use when we mean going in the hospital, going to the rehab, coming home. After any type of hospitalization, I think it's good to bring in the pills if you can. Also, as I said, carrying a printed medication list with you, very, very helpful. Having the doctors to communicate with one another. So the way I try to do this, I'll give my patients my cards and I'll say, next time you go back to that orthopedic surgeon, give him my card. Ask him to send me a copy of his note. Because again, it's one of those, oh, you're in the computer, and then the doctor at Bryn Mawr doesn't know who I am, and I never get their note. What else? Oh, when you're hospitalized, giving them, the doctors taking care of you, the name of your primary care physician. Again, similar to what I just mentioned with the other consultants. Asking them to send a report to the doctor, to your primary doctor. And finally, reporting over-the-counter medication use. So whenever you see your doctor, if you did start taking something, we're not going to yell at you. We just need to know what it is so we can account for everything that we're doing with your medications. Okay? So that's my kind of tips for coping with this problem of the medication list being incomplete. There are probably more things that we could share, but I'll move on to the next problem for now. Okay, so this is the issue of medication non-adherence, or patients who don't take the medications as they are prescribed. There's a number of reasons why people would not be taking the medications as prescribed, such as just a few here: forget to take them. That's understandable. Lack of understanding, maybe not really knowing you had to take that medicine every day. Sometimes people think that their antidepressant was just for once in a while use. Well, they don't work like that. You have to take them every day for them to be effective. Side effects, people not wanting to take the medications because they're getting a side effect from it. Cost, I mean, and this is one that's always sometimes a particularly challenging issue because people are embarrassed. They don't want to tell someone, let alone their doctor, that they can't afford that medication that we gave them. And it always breaks my heart whenever I somehow fail to detect that. And I try to really assess that with all my patients. Just too darn many pills to deal with. I mean, understandable. Depression, just not feeling motivated, not feeling like you can cope with everything and all the pills. And then again, people with some memory problems, dementia, who aren't able to coordinate and understand how to take all their medications. So what can we do about this issue of not taking the medicines as prescribed? So first of all, a pill box is a great way. Everybody in here use a pill box or recommend their family uses a pill box? Yeah? Simplifying the medication schedule. You know what? Be frank with your doctor and say, Doc, I can't remember to take this 3 times a day medicine. Because when I hear that, then I'll try to come to another solution for treating that medical problem. Understanding what the medications are used for. I try sometimes, if I remember, to write on the prescriptions, take daily for blood pressure. It should be on your medication label so you know what this stuff is for. Or if you don't know, ask, and don't be afraid to ask over and over again. Discuss side effects. So again, people who just stop taking medicines because they're having some sort of effect that they attribute to the medicine. Discuss it with your doctor, or better yet, discuss it with your pharmacist. So remember I said I used to be a retail pharmacist. I used to love when people would talk to me. It's so boring back there. You're just like typing into the computer, calling the insurance. I would love it when people would come up with a question that actually used my medical knowledge. So your pharmacist knows a lot of stuff. When drugs get approved and when they get studied, they basically have to report any effect that any patient reported during the trial. So if they were taking whatever, I don't even know what medicine it was, the Lipitor, and their pinky finger hurt, well, then they have to put pinky finger pain as a side effect. I mean, it's just the way it is. So that's why there's just, this list is just unbelievable. All right, don't be scared by it. Just talk to us about it. To deal with the cost issue, so generics. I prescribe generics. I have my family take generics. I think there are very, very few instances when a generic is suspect. There are a couple drugs that you don't want to switch back and forth between the brand and the generic, such as thyroid medications and such as things like blood thinning medicine like warfarin or Coumadin, just because those drugs are, you need to keep a certain blood level and you might not get the exact same absorption from brand versus generic. But most of the time, I think generics are fine. They'll save you a lot of money, saves the whole system a lot of money. The $4 medications that you can get at Walmart and Target, what a great invention. All right. And one other thing, we talked about patients with memory loss having a difficult time remembering to take their medicines. So these folks really need some supervision. So I always encourage family members, friends, whomever, to try to help with that sort of thing. Okay, so here we go. So the next problem is adverse drug reactions. So definition of an ADR, an adverse drug reaction, is any harm resulting from a use of a medication at the normal dose. And somebody's probably going to ask, what's the difference between an ADR and a side effect? They're kind of similar terms. It's really a matter of degree. Think of a side effect as something that occurs when you're taking your medicine just in your normal course, and it's maybe part of the pharmacologic way the drug works. So you take your pain medicine, but it also makes you a little sleepy. That would be a side effect. But the harm would be more if you take it, I guess, and you fall and break your hip. That would be considered more of an adverse drug reaction. Don't get caught up in all the terms. Older adults are 7 times more likely to have unwanted side effects and 2 to 3 times more likely than younger folks to have adverse drug reactions. They're really at risk. One really important point here that I teach to all the residents and medical students is we have to adjust the dose in older adults, oftentimes because of the kidney problems we talked about and the changes in how the body handles drugs. So sometimes not adjusting the dose down can cause these side effects. And then a lot of a whole wastebasket here of terms. Drug-drug interactions, so the drugs interfering with each other can lead to harms. Drug-food interactions, maybe never thought about this, but some medicines say if you take your calcium and your thyroid pill together, your calcium won't get absorbed. Or, I'm sorry, your thyroid medicine won't get absorbed because it binds to the calcium. That would be a drug-food interaction if you're taking it with milk, for example. Drug-alcohol interactions. Alcohol causes vasodilation, causes the blood vessels to get wider and the blood pressure to drop. So alcohol with some blood pressure medicines can be very risky. And drug-disease interactions. As I spoke of before, somebody with heart failure or fluid buildup problems who starts taking medicines like anti-inflammatories over the counter, that can really affect you and make you build up more fluid. So first of all, ask your doctor to check for drug interactions. So in my other life as an educator, I work in trying to teach the people at Penn, the medical students, the residents, the practicing physicians, how easy it is to check for drug interactions. We can type them all into the computer and hit a button, and within 30 seconds, it'll check for interactions. I think the scary thing is it might pull up about 10, and maybe only 1 or 2 are relevant, and I think people just get very scared by all that data in your face. But it's important. So don't be afraid to ask your doctor, is this okay with my other stuff that I take? Or ask your pharmacist. And ask your pharmacist, I should say. Again, reporting all medicines, I think I've said this 10 times now, but I'll say it again. Prescription medicines, over-the-counters, herbals, topical things that you might not even think about, steroid creams or whatever, even eye drops. You know some of the medicines for glaucoma, timolol, it's what's called a beta blocker. It can actually get absorbed and make your heart rate lower in some people. Okay? Not everybody is that sensitive to it, but we should know what you're on. Okay. I think I said this 10 times too, asking the doctor or the pharmacist before you use any new over-the-counter or herbal supplements. It's not that hard to just put a call into the doctor. It might take a couple days for us to get back to you, but really, just checking with us before you take something could really benefit you in the long run. Report any new symptoms or side effects, again, to the doctor or the pharmacist, and like we learned from our pal Ida at the beginning, take only your own medications. And a word about the herbal and the dietary supplements. Again, just a reminder, these are medications, like we said. They can interact with any other medications you take. I'll give you an example. Some people will take something called St. John's wort, commonly used for depression, for mood disorders. It has a compound in it called Hypericum perforatum, and it actually works in a manner similar to the SSRIs, which are serotonin-specific reuptake inhibitors, Prozac, Paxil, Celexa, Zoloft. And so if you started taking that and your doctor put you on an SSRI, you could actually get toxic and have a really serious reaction. So it's really important to tell us what you're taking. These drugs also, or these products, aren't as closely regulated as other medications, so they don't get approved by the FDA, they don't get studied for safety and efficacy in the same way that other drugs or medications do. They're also not inspected for the quality in manufacturing, so I find this very scary, that you could be purchasing something and taking it and not knowing if you're actually getting the milligrams that it says that you should be getting. I guess some ways around this are to use a reputable manufacturer. I don't know the names of any off the top of my head. Maybe the pharmacist would know. Or again, some people are very into these nutraceuticals and maybe they know a reputable manufacturer. And again, gee, I'm a broken record, reporting the use of these products to your physician. Okay. One other thing about the herbal stuff I always want to mention, that if anybody uses any of the ones that start with a G, ginkgo, garlic, ginseng, it's probably another one I'm forgetting. These ones all can affect your platelets or your body's ability to clot. So if you are taking those and you go for dental work or a surgery, you could have a chance of having a problem with bleeding after the procedure. So, all right, so drugs with increased risk in older adults. I'm telling you, we could lock those doors and I could keep you guys here all night and talk about this forever, but I won't. So I'm just going to try to focus on a few common problems that we see. So falls, which can lead to injuries, hip fractures, which can be completely detrimental to older adults. Confusion, some worsening of heart conditions like I alluded to before. And this is where I want to remind you about my little disclaimer that do not be alarmed if you take one of the medicines that's on the next slide, okay? your doctor who gave it to you is a good doctor. They just need to make sure that they talk with you about the side effects and the risks of these medicines. So, okay, big one, like in flashing lights, sleeping medications. Some people in here, I think, I take care of some of their relatives, so they've heard me or speak about these things before. But sleeping medications are tremendously risky. Oh, no problem. In older adults. And so this is your things like your Ambien, the Lunesta, any of the Ativans, all those sort of things, which we're going to get to some more. And it also includes over-the-counter medicines. So a lot of people are self-medicating with the Tylenol PM, the Unisom, the Benadryl, and this can cause confusion, risk of falling, breaking a hip. Also medicines that are used for nerve pills, anxiety, so things like, we call them benzodiazepines, your Ativan, lorazepam, Xanax, Valium. These medicines have a wide prevalence of use, and especially in older adults, and you can see why. I mean, there's a lot of anxiety associated with getting older, and seeing illness in your friends and loss and all the stuff that happens. And a lot of people are very anxious, and quite frankly, sometimes I say it's easier to give a pill for this and give a prescription for this. It takes 2 minutes to write than it is to talk for 15 minutes about why we don't want to use that. Or there are some patients in whom the medicine really is beneficial and the benefit outweighs the risk. So, but in general, these medicines have been proven, studied, and shown to be associated with the risk of falls and, again, hip fractures. Barbiturates, things like phenobarbital, are also in that category. Even some antidepressant medicines have been associated with a risk of falling, and increased confusion. Pain medicines, again, this is such a double-edged sword because narcotics, I mean, if you have pain, who gets arthritis and these pains are the older adults, and who has the side effects from these medicines? The older adults. But just be aware that any pain medicine does cause sedation, confusion, risk of falling, and being unsteady. Also medications for neuropathy, things like gabapentin and Lyrica that people take, if you've ever heard of those, also similar effects. And another one people are sometimes surprised by is the muscle relaxants, so things like Flexeril, Robaxin, Soma, that people are on a lot, can cause similar problems. Worsening of heart conditions, I think I mentioned this already now, the anti-inflammatory medications leading to fluid retention. Edema is another word for fluid retention. Worsening of heart failure, and even blood pressure. Sometimes I'll see patients whose blood pressure was well controlled, and all of a sudden it's like 10, 20 points higher than it was before. And I'll say, are you taking anything over the counter? And sure enough, they might have started taking some Aleve or something like that. And that, again, just by the mechanism of holding on to salt and holding on to fluid, it can raise your blood pressure. Think about it. When your doctor tells you that they want you to lower your blood pressure, they want you to cut out salt, right? So through the ways that these medicines work, through the kidneys, they hold on to salt. So they counteract all your good work with your diet. And decongestant medications are another one. So things like Sudafed over the counter. Anybody who's taking blood pressure medications needs to be wary of taking over-the-counter decongestants. A solution that I would say sometimes, if you're really just congested but you have problems with blood pressure, using something like the nasal sprays, so either a nasal saline or even just a nasal spray Afrin, just for a couple days to get you through that annoying time of the cold when you can't breathe and you can't sleep. That's a good way to get around it. So the solutions to this is kind of intuitive, I think, trying to avoid, if possible, the risks or the medicines associated with an increased risk in older adults. The sleeping medicines, somebody's probably out there saying, well, how am I supposed to sleep without a sleeping medicine? There's a lot of things we can do that are non-drug related, looking at caffeine intake, looking at are you napping during the day, is there some other medicine that's causing you to not sleep, some other problem? Is it depression, is it pain? So trying to really rule out every single thing before we go to the sleeping medicines. Trying Tylenol first for pain. First line in osteoarthritis, Tylenol round the clock. You can use up to 1 gram 4 times a day if you don't have any liver problems or drink alcohol heavily. And finally, consider talk therapy for anxiety instead of those medicines that I mentioned, those benzodiazepines. A lot of people are resistant to that, especially I find in older adults. Just the concept of sharing things like that with some stranger is very uncomfortable, but it can be very beneficial and get you off those medicines. All right, and number 5, in the home stretch here, so this problem called polypharmacy. This is one of the geriatric syndromes that geriatric physicians like myself kind of specialize in managing. So this really just means taking more medicines than necessary. There's not really a specific number. People want to say, how many is too many? Well, I don't know. Studies have shown that like 5 or more medicines are when you're going to have more problems with drug interactions, with problems with adhering to the therapy. So if you want to have a number, 5 being a risky number, but really just even taking one medicine that's not indicated is too much. So the causes of polypharmacy are a lot of things we've talked about over the past hour. People having multiple medications, or multiple medical conditions for which they end up on a lot of medicines, multiple prescribers, multiple pharmacies. That's another thing, right? You're getting some filled here, some filled there, and they're not talking to each other either. And then there is sometimes, in some patient populations, an expectation to get a medicine for each problem. They go to see the doctor, and we kind of feel like we have to give you a medicine too. So it goes both ways. And then before you know it, you got like 20 things to take. And polypharmacy leads to increased risk of these adverse reactions like we talked about before, not taking the pills as ordered, and even just higher cost to the healthcare system in general. So some solutions here. So make sure each pill has a reason for being used. Like, doc, why am I on this? Is it possible to reduce this list? And like we said, asking your doctor to do a periodic medication review. I try to do that. A lot of times I'll go through every medication, every visit with my patients, but that gets to be a little bit cumbersome. Sometimes if there's other things, more on the priority list, you just can't do it every time. Bring it to their attention. Bring it to our attention. Trying non-drug measures first. Whatever, a heating pad for your back pain, or exercise, or massage, acupuncture. Be aware of something we call the prescribing cascade. This is more for us docs to worry about, but I want to mention the issue with you guys too. Treating a side effect of one medication with another medication. So I'll give you a quick example of how that could work. So say you've got a man who's got an enlarged prostate and he gets a cold. Okay, fine. So then he takes some Sudafed for his cold. Well, in men with enlarged prostates, that can cause you to have urinary retention, being unable to empty the bladder. All right, so then you go to see your doctor. You don't tell them you're taking the Sudafed. Then he puts you on a medicine for the prostate, which say it's something called Hitrin, which can cause dizziness. All right, so now you're on your Sudafed. You got some Hitrin, which makes you dizzy. Then you go to the emergency room because you're dizzy, and then they put you on Antivert or Meclizine, which treats the dizziness. But really, the whole problem got started because you took the Sudafed, okay? Or he took the Sudafed. So you can see how very easily. And I'm telling you, I probably miss it. I probably missed it today. We all fall victim to this. The doctor should always think, could this symptom be caused by a drug? Okay, and you should feel free to ask them, could this be a result of anything I'm taking? Trying to use only one pharmacy again so that all the medicines are in the same computer and they get checked for the interactions. And finally, you may want to consider seeing a geriatrician. This is almost a little self-serving advertisement portion of the talk, but not meant to be so. But really, I think that geriatricians have expertise in this area. And even if you or someone is, you have an internist, you really like your doctor, you can still go just for a consult and see a geriatric specialist. Maybe see them once a year, maybe see them every 6 months. And just do a little check-in, but still keep your regular doctor. That's perfectly acceptable.